Welcome, everyone, and thank you for coming to the Heart Forward studio. And we're going to kind of kick it off here and just explain first kind of what Preventi is, because Preventi is our sponsoring company, and Preventi AI is a preventative cardiology company. And I just wanted to sort of explain first how that fits into everything. And it's kind of a simple concept to describe, and that's why it's named that way. We really wanted it to convey a message that it's a preventative forward company, and it's basically connecting high resolution cardiac CT imaging with AI powered plaque analysis, and also a real conversation with a cardiologist, board certified cardiologist, who looks over all the information and provides a whole picture analysis. It's not just the cholesterol number, it's not just family history, and it's not just one risk score. This is the whole picture. So Preventi is encompassing a whole preventative cardiovascular package. Preventi AI was built for one reason. And again, most heart disease is preventable, yet it remains the number one cause of death in the country and globally. The gap between what the science knows and what most people actually receive in care is what we're trying to close. And we're not doing it alone. That's why this series exists. So today is the start. It's the kickoff, session one of 12 conversations we'll have, one per month over the next year, with some of the best minds in cardiology, primary care, lifestyle medicine, and longevity science. Really, preventative health matters. And here's what should bother each and every one of us. 80% of heart disease is preventable. 8 in 10 heart attacks and strokes never had to happen. And yet, every 40 seconds in America, someone has a heart attack. Why the gap? Because the system we have built to treat disease, not to prevent it. A typical primary care visit is 15 minutes long, and the average patient sees their doctor 4 times a year. That's an hour of real attention total of the most important machine in your body. In that hour, the question is almost always the same. Are your labs normal? If yes, we move on. If no, we adjust the medications and order some follow up. But here's what the modern science of prevention tells us: normal labs are not the same as low risk. Half of heart attacks happen in people with normal cholesterol, people with a clean lipid panel, a stress test that looks fine, and a family history they've been told not to worry about. By the time the standard tests catch up, it's often too late to prevent and only late enough to treat. So, whether you're a patient, a primary care physician, or someone running a longevity practice, the question we should all be asking is different. Not are the numbers normal, but what actually happens inside the person's arteries right now and what we can do about it today. That's the question Dr. Almeida and I want to spend the next 20 minutes on. So I want to introduce my colleague and friend, Dr. Shone Almeida. He's joining us today as our first special guest, and he's a cardiologist who has spent his career in the gap between what cardiology can do and what most patients ever experience. He practices at USF Health System and sees patients across the spectrum from worried well to acute, and brings a perspective that bridges the academic and everyday. Dr. Almeida is a preventative cardiologist, and he also is a CT enthusiast and well versed in the advanced cardiac imaging world. So, welcome, Dr. Shone Almeida, and welcome to the program.
Good morning. Good afternoon, I guess. And really, thank you. Thank you for having me. A pleasure to be part of this.
Great. Fantastic. So we're going to do a couple of questions and you just kind of give us your perspective on where and how this fits into cardiology, preventative care, and the current new trends or new access to advanced cardiovascular imaging. Meaning, when I say advanced cardiovascular imaging, I'm talking about, in this case, advanced cardiac CT imaging.
Fantastic.
All right. So, question one. I want to start with a patient archetype that walks into both of our practices really every week. Cholesterol looks fine. Stress test is unremarkable. The primary care doctor told them to come back in a year, but they have a parent who had a heart attack at 55, a sibling on a statin, or feeling uncertain that they just can't shake. What's the first thing you do when that person sits down in front of you?
So first of all, let me just commend the preamble that you gave at the beginning of this, because I think you hit a lot of critical points. I think where cardiology has moved is a lot of reaction and not prevention. In the patient that you were describing, our focus so much is on numbers, statistics, population-based risk scores. And we think that we can easily package these patients up into clean boxes of risk, low, intermediate, high, because based on cholesterol or weight or how they look on the outside, or based on their lab biomarkers. And the flaw with that thinking is that you really don't know what someone's vessels look like until you go looking, and it's as simple as that, right? It's a just look principle. So in the individual you're describing, sounds like they have some elevated cholesterol. Sounds like there is some family history of at least some atherosclerotic disease. Other members of family with high cholesterol. To me, a good starting point is certainly with a good history, right? Let me understand a little bit about what symptoms you may have, how active you are, what is your diet like, what comorbidities do you have that I think could be contributing to cardiovascular risk. So besides high cholesterol, is there high blood pressure involved? Is there diabetes? Is there overweight, obesity at play? For my female patients, is there premature menopause? Are you postmenopausal? Because we know that heart disease risk increases after menopause. And then there's some other subtleties, right? So, are there chronic inflammatory conditions that I should be aware of? For example, men with HIV or lupus or rheumatoid arthritis. I mean, these are some chronic inflammatory conditions that we know and recognize increase atherosclerotic risk, heart disease risk. So in the individual you're describing, what I see a lot of my colleagues do in cardiology is that they get plugged into population-based risk scores, and we take those risk scores as worth their weight in gold. And we say, well, your risk score says you're at 1% risk for a heart attack in the next 10 years, and therefore nothing further needs to be done at this time. And the flaw, I think, in that thinking is that population based risk scores, particularly as they perform in younger patients and especially in women, are known not to be very well, right? So we know they underestimate risk because they're so age and gender weighted. And so in this kind of individual, I want to, especially when I see risk factors, go beyond what we do traditionally in cardiology, and that is use cardiac CT technology to directly visualize the heart, directly visualize arteries, and see if I can find previously undetectable disease. So that's subclinical disease. Because the second we find plaque, by definition, you have heart disease, and that will completely change how we take care of you.
Thank you. Those are great points. Next question. What's the single biggest misconception you encounter from patients or referring physicians about heart disease prevention?
Gosh, that's a really important one. I think, I'll give it to you from two perspectives. From the patient's perspective, I hear a lot of patients who feel like they're eating right, eating healthy, eating cleanly, however you define that. They exercise, they're runners, they lift weights, and they have no symptoms. And the second an event occurs, And I don't know what's been going on post-COVID, but I see a lot of younger patients in their 40s and 50s with heart attacks. When that first event occurs, it catches them by surprise, and they say, "What happened? How could this have happened? I'm the epitome of health. I exercise, I eat good, I don't smoke, I don't do all these things we've been trained not to do. How could this have happened?" And the misconception is that what's on the outside mimics what's going on the inside, and that's not always the case, right? There's a lot of genetic and environmental undertones that we have no control over that could be dictating a cardiovascular risk and presence of disease. And unless you are an aggressive, unless you go looking at these things aggressively and intentionally, you'll never find it. On the
Really,
provider, yeah, say again.
those are really powerful comments. It's an important point and concept.
Yeah, I can't look at someone, I can't look at you, Jim, and say that as, good looking as you are and as strong as you are and as the fitness that you do, that you have a clean bill of health. I simply cannot say that because we don't do a good enough job at assessing what all of the different parameters that feed into heart disease risk and the presence of disease. And so am I willing to take that gamble and say, well, Jim looks pretty good. He's not obese, he doesn't smoke. Let me leave him alone. I don't think that that gamble is worth your life. I would frankly take it to the next level and go look for disease proactively, particularly if there's risk factors. And I think the same kind of misconception carries over to the provider level. I think we're so, physicians in general are very intelligent people, right? We get trained very well from undergraduate years to medical school and beyond how to talk to patients, how to assess risk, how to take a history. But I think what happens sometimes is that medicine has become so algorithmic and so score based that we forget what's right in front of us. And so if you start hearing a patient where you're not quite putting all those puzzle pieces together, if I have someone in their 40s and 50s with high cholesterol, oh yeah, you used to smoke for 10 years. Oh, and also, yeah, what happened to your father with a bypass at 55? These should trigger some red flags in your mind. You should probably take this person's risk assessment to the next level, maybe beyond just statistical risk scores to say, how else can I further adjudicate risk in this person? There's something here that doesn't quite feel right.
And this is why it remains the number one killer. Like you said, there's such a gap. And that's why, because of the tools we've had to use, and that it can strike out of nowhere. And, you know, a heart attack in your early use, really.
I think it's interesting, Jim. I think, so much of what we've been talking about for the last 2 decades has been a cholesterol focus, right? You can take anyone off the street and you say, "Hey, do you know about good cholesterol and bad cholesterol?" Most people can tell you, "Yeah, I kinda know the difference," right? They may not be able to tell you specifics, but they can say, "Yeah, good cholesterol is good for you, bad is I should keep that low." They can tell you bad cholesterol comes from eating too much red meat, right? So we create these patterns of recognition in our mind that red meat good, red meat bad, chicken good, right? Or LDL bad, HDL good. We create these sort of simplicities in our mind. And the fact is, heart disease is so much more complex than that. And so if you're simply using a surrogate marker of disease like an LDL cholesterol to assess your risk, I think we're going to be very flawed in identifying disease early.
I agree with you. Um, all right. What do you think has changed in preventative cardiology in the last 5 years that the average primary care doctor or patient may not realize yet?
Well, a lot has changed. So I guess I'll start with we can even go back 10 and 20 years, right? So the coronary calcium score is a very cheap, easily accessible test that for most patients will work really well. So a coronary calcium score, for those who may not be aware, is a simple CT scan. No, there's no contrast, no IVs, no needles, no medication. It's simply like a mammogram for the heart. And so if you're a man over 40 or a woman over 45, this is a good screening test for heart disease. The problem and the flaw with simply relying on a coronary calcium score is that you're kind of looking at just half the picture, right? And I use this iceberg analogy quite a lot. So calcium score is trying to look at tips of an iceberg, and you're as a ship captain looking for tips of an iceberg as warning signs. Hey, these may be some difficult waters we're going into. Let me chart a different course. The problem with an iceberg is there's a large mass below the surface. And when it comes to the heart, that large mass is typically soft plaque that a calcium score will never show you. So if you're on the older spectrum, let's say 65 plus, and a calcium score is 0, great. I'd say you're in pretty good shape, lowest risk. But if you're in your 40s, 50s, early 60s, and your calcium score is 0, but you carry several risk factors, strong family history of premature disease, you've smoked before, you're diabetic, you're overweight, you have high cholesterol, a calcium score of 0 can be falsely reassuring. And so, what has dramatically changed in the last 5 years is that physicians have started to look to coronary CT angiography. That is a heart CT scan, just like a calcium score, except now with contrast. So now you get the full picture. You see the tip of the iceberg, but you can see below the surface as well. Hard plaque, soft plaque, and assessment of heart vessel narrowing to find disease in its earliest possible stage that our current technologies allow. And the whole point of this is for early intervention. Find disease, treat disease early, and then keep an eye on it.
What what do you wish that primary care physicians who are doing their best in a hard system were able to catch earlier? And what do you think patients could be asking at their next visit to make that easier?
Gosh, I think patients are going to be their own best advocate here. So I think what we should be, but certainly I think primary care physicians should be adopting and tailoring their practice to the 2026 cholesterol guidelines. And the highlights there are essentially treat to lower targets, right? So if you have disease, treat to lower cholesterol targets. That we should have a lipoprotein A screening test done on everybody once in your lifetime. This is part of the new guidelines released this year. Um, and I think the guidelines do a really good job of actually helping primary care physicians come up with a treatment algorithm. The issue is those guidelines only kick in once you recognize risk. And so how can we help our primary care colleagues recognize risk a little bit better? The new prevent risk scores are more accurate. They work a little bit better in younger patients. They work a little bit better in women as well. But I think using imaging to find and treat early disease is something that I want our primary care colleagues to start to recognize and embrace a little bit more than we have. Even coronary calcium scores, I think, as much as those have been around for the last 2 decades, are still very much underutilized in our system for men and women above age 40 and 45, respectively. So even simply thinking about coronary calcium scores, just as you think of it as a mammogram, how can you start to use that to at least have a very early conversation with patients about their risk? And in those patients with many risk factors, looking beyond a calcium score and not letting yourself be falsely reassured of that score 0 in a high risk cohort.
If you could give one piece of advice to a person listening today, about 50 years old, feels healthy, like we spoke about, uh, but has that family history of heart disease, what's a concrete next step you would tell them to take in the next, say, 30 days?
Yeah. So 50 years old, a man or a woman, you have a family of heart disease, you have known high cholesterol. The first test that comes to my mind is a coronary CTA. So coronary CT scan with contrast. Now, this isn't found in any of our cardiology guidelines yet, but as we often recognize, guidelines lag behind innovation. The reason I'm a big proponent for coronary CTA in this group, so you've already identified yourself as being in your 50s, meaning your risk is higher. You have high cholesterol. So now the question is, do I need to be on treatment? Number one, and how aggressive do I need to treat? And both of those questions get very nicely addressed with a coronary CT scan. Because if you can find disease and find early plaque, now we have a diagnosis of heart disease that warrants automatically more aggressive treatment goals. And more importantly, we can use AI technologies for plaque analysis to start to quantify your disease burden and characterize what kind of plaque we're dealing with, right? So one of the things we recognize, Jim, in through research innovation in the CT world, is that not all plaque is the same. Dense, hard calcified plaque is actually more protective relative to soft, non-calcified, necrotic, or lipid-filled plaques. And so if you can start to quantify and characterize what kind of plaque you have, now you can start to treat to plaque and not treat to just an LDL target. And that's a major, major shift in paradigm in how we manage heart disease and cardiology.
Yeah, I agree with you. From the other side, radiology, where I've been looking at direct visualization of the plaque over years. It's always been interesting to me too, as we understand plaque phenotype more and more. We actually have changed the names over time, right? At first, we first called there was calcified and non-calcified plaque, or calcified and soft plaque. We changed from soft plaque. I think from soft plaque we went to non-calcified plaque to vulnerable plaque, and now we're at high risk plaque. So
Mhm.
basically, really describing how significant that non-calcified plaque is. So you understand right away when you're naming something high risk plaque, you know how significant that is to directly visualize. And these newer tools that we're able to visualize with, like you said, moving towards the innovations and CT and direct visualization is so powerful to the overall health and the public health issue.
That's right. I agree with that.
So that's a lot to land in 20 minutes, I think. And maybe if I had to summarize, maybe I summarize three things I had here. Normal labs are not the same as no risk. The standard checkup is not necessary, but not sufficient. It's necessary, but not sufficient. Um, if you had to wait, there are tools and conversations available right now that can change the picture. Whether you're a patient asking your doctor better questions, or a physician thinking about how to serve your panel.
Mm.
Prevention is personal, right? It's not a one size fits all checklist. It's a real conversation between you, your body, and your family history, and a doctor who has time to listen. And that's the conversation we're going to keep having once a month here for the next year. And session two will be coming up July 22nd. That's a Wednesday. Um, and I wanted to thank Dr. Almeida for today. And do you have any questions for me, or do you want to end with any thoughts for us?
I actually have
Well,
one we have one live question, if I can
okay.
jump that
Yeah.
in. So, in a patient with normal lipid profile, normal blood pressure, but overweight and a family history of heart disease, would CCTBTA be the best screening tool? As you indicated, it is not listed in guidelines for screening. How do you convince insurers to cover these exams? How do you convince providers to order such exams for screening?
Right. So without knowing a lot of the other details, I think a couple things come to mind. I think, as a cardiologist and someone who takes care of a lot of patients like this, I see myself as being a steward not only for these technologies, but also for doing this safely. So, for example, if you're someone with the risk profile that was described, but you're a 30-year-old or 35, I might say, okay, listen, you got some lifestyle changes that really need attention here, addressing weight loss, addressing diet to fix cholesterol. Maybe I don't want to subject you to a scan just yet. But if you're on the older side or slightly older, let's say 40s, mid 40s, early 50s, then this changes a little bit because now I know that you've been in this lipid rich environment for decades. That pretest probability of having subclinical atherosclerosis is on the higher side. So I think this individual does make sense for coronary CTA as long as they're then willing to take the next step. The next step being major aggressive lifestyle changes to lose weight, to change diet, but then also think about pharmacotherapies, right? So are they willing to take statins? Are they willing to consider GLPs? There's so much more that we have in our arsenal now to address cardiovascular risk beyond just addressing cholesterol and taking a statin. There's so much more that we can offer. And I think that's a big takeaway for patients. And then to the second point about, well, how do we get providers to pay for this? I think this will take time. So CT-derived plaque analysis only got a Category 1 CPT code for reimbursement through Medicare this January. A lot of commercial payers haven't quite picked this up, but they tend to follow what Medicare does. So this will take time. How does CT move into the proactive asymptomatic realm for reimbursement? Well, that'll take even longer. You see how long it's taking even for a simple calcium score to get coverage. A lot of my patients still pay out of pocket for that. So I think this will take time as guidelines and more clinical trials are done to find out, does this impact outcomes, reduce heart attack risk? A lot of retrospective observational data suggests that this is a strong yes, but we do need some outcome trial prospectively to show that this kind of method of treating patients actually reduces heart attacks.
Do we have any other questions?
No, there's no other questions. Thank you.
Thanks, guys. And we'll see you all next July 22nd.
Fantastic. Thank you so much for having me. This was fun.
Thanks, Shane.